Good evening, everyone. I will like to thank the organizers for giving me this opportunity. So the topic given to me is redefining the standard of care for postmenopausal hormone-positive, HER2-negative advanced breast cancer. Next slide. Next slide. So in this talk, we will be discussing a patient-based case study, and we will be discussing different points. What are the approach considerations? What are the goals of the treatment in this patient? What is the role of CDK4 inhibitors in advanced breast cancer patients? What are the currently approved CDK4/6 inhibitors? What are the latest NCCN SO guideline recommendations about postmenopausal hormone-positive HER2-negative metastatic breast cancer patients? We will have a brief discussion about MONALEESA-2 study outcomes. We will have a ribociclib comparison with other CDK4/6 inhibitors so that how we can choose between the different CDK4/6 inhibitors in our clinical practice. Next slide. So there is a patient profile. There is a 63-year-old woman who presented to her healthcare provider with a lump in her breast. So on examination and workup, she had a 2.1 centimeter right breast mass, 2 palpable axillary lymph nodes. USG and mammogram confirmed these physical findings. So she's a T2N1 disease on clinical examination. So by her healthcare provider, she was referred to a medical oncologist who did a core needle biopsy that showed it to be a hormone-positive, HER2-negative breast cancer. ISC score is, I think, wrongly written here 3+. It is HER2-negative. So on CT scan of the chest, abdomen, and pelvis, there were 2 liver lesions. MRI brain was negative. So she is a metastatic breast cancer patient, postmenopausal, who is hormone positive and HER2-negative. Next slide. So what are the treatment goals in this patient? So most important treatment goal, I think, will be to prolong the survival. Because in metastatic settings, we have very good agents now available, so we can, which can prolong the overall survival of the patient. Second will be, as it is a palliative setting, to restrict the treatment-related toxicities is also important. Symptomatic relief is very important for patients who think a survival and other things as a data only. The things matter to them is symptomatic relief first, and then the quality of life. Next slide. So what is the management algorithm for hormone-positive, HER2-negative advanced breast cancer patients? So the first-line therapy, the options to us are either to use aromatase inhibitors or tamoxifen alone, which are not preferred genes according to NCCN guidelines nowadays. So the NCCN now says the category 1 recommendations are the combination therapy, which can be either in the form of aromatase inhibitors plus CDK4/6 inhibitors or fulvestrant plus CDK4/6 inhibitors. So if we have used aromatase inhibitors or tamoxifen alone, then in the second line therapy, we have the option of fulvestrant combined with CDK4/6 inhibitors and reserving exemestane or everolimus for third line therapy or chemotherapy in some patients. So if we have used the combination therapy in the first line, which is the preferred recommendation nowadays in the form of aromatase inhibitors and CDK4/6 inhibitor, then in the second line we have the option of fulvestrant, and in the third line exemestane or everolimus. Next slide. So what are the international guideline recommendations? ESMO, ESCO, and NCCN, they all agree on one point, that hormonal therapy is the mainstay treatment for patients with hormone-positive, HER2-negative, advanced or metastatic breast cancer patients. So nowadays, the role of chemotherapy in hormone-positive metastatic patients is declining day by day, especially with the advent of newer agents. I will say CDK4/6 inhibitors and PI3 inhibitors. So these drugs have really changed the treatment landscape for hormone-positive metastatic breast cancer patients. So CDK4/6 inhibitors combined with aromatase inhibitors as the preferred first-line hormone therapeutic option can confer 40% overall response rate and median progression-free survival of about 2 years for hormone-sensitive patients defined by aBc2 guidelines. Next slide. So what is the role of CDK4 inhibition in advanced breast cancer patients? CDK4 plays a key role in breast cancer tumorigenesis and cell proliferation. The levels of CDK are upregulated more than 8 times compared to the levels of CDK6 in breast cancer cell lines. So specifically inhibiting CDK4 more than CDK6 may confer a clinical benefit. The inhibition of CDK4 has been shown to block the ability of breast cancer cells to form tumors. Next slide. So what is the rationale of targeting CDK4/6 inhibitors in these kind of patients? So this is a diagram of the cell cycle showing different phases, G1, S, G2 and M phase. So what are the most important things in this diagram? The estrogens, the estradiol hormones act as growth promoters. They bind to the estrogen receptor, which via the downstream signaling pathways of PI3K, cyclin D, MET, ERK and other molecules leads to cell cycle progression and cancer progression, tumorigenesis. So the mitogenic pathways, including estrogen signaling, stimulate cyclin D production. Binding of cyclin D activates CDK4/6. So how these molecules act? So in normal conditions, the tumor suppressor retinoblastoma gene inhibits the E2F transcription factors, which are responsible for the cell cycle progression for the G1S checkpoint. But in when the estrogen stimulates these estrogen receptors and activates the downstream signaling pathways, then the cyclin D forms a complex with cyclin CDK4 and 6, which inhibits the retinoblastoma RB tumor suppressor gene and inhibits the E2F transcription factor so that it can activate the cell cycle, continue the cell cycle progression. So we have mainly the 3 targets in the cell cycle. Either we can inhibit the estrogen hormone, that we can do by aromatase inhibitors, or we can inhibit the estrogen receptors by fulvestrant, which is a selective estrogen receptor downregulator, or we can target the downstream molecules. So in patients who progresses on endocrine therapy or have endocrine resistance, there are various pathways by which endocrine resistance happens. It can be due to overactivation or amplification of the estrogen receptor, or it can be due to the overactivation of the downstream pathways. So the rationale is to combine both the things. First, we inhibit the growth activation by estrogen or receptor, and also take care of the downstream signaling pathways to prevent the endocrine resistance. So selectively inhibiting CDK4/6 causes cell cycle arrest in G1 phase, resulting in reduced cell viability and tumor shrinking. Next slide. So how to choose a CDK4 inhibitor, CDK4/6 inhibitor? Stage of the breast cancer is important because recently abemaciclib has been FDA approved for the adjuvant settings also, while palbociclib and ribociclib are only approved in metastatic settings. Treatment history of the patient: if we have if the patient has already progressed on a CDK4/6, we can't use it again. A relapsation rate of cancer, type of patient, the side effect profile, because all the CDK4/6 inhibitors have different side effect profiles. What is the treatment team preference, either ongoing therapy or 3 week on and 1 week off, and other financial issues can also be there. Next slide. So CDK4/6 inhibitors in advanced breast cancer. Investigation into CDK4/6 inhibition in combination with endocrine therapy have significantly altered the treatment landscape. In the first line setting, the addition of CDK4/6 have significantly improved progression-free survival, overall response rate, and clinical benefit ratio versus endocrine therapy alone. Next slide. So these are the clinical trials on the approved CDK4/6 inhibitors. We have PALOMA-2 trial, which was a first-line setting trial. In this trial, letrozole was combined with palbociclib. 666 patients were there. It showed a progression-free survival of 27.6 months versus 14.5 with letrozole alone. We have Mona Lisa 2 trial in which letrozole was combined with ribociclib. Again, 668 patients, PFS benefit of 25 versus 16 months. Monarch 3 trial, letrozole or anastrozole plus abemaciclib, PFS 28 versus 14 months. Mona Lisa 3 trial, it included patients of both first and second line, fulvestrant with ribociclib, 33 versus 19 months. And Mona Lisa 7, first line trial with tamoxifen, letrozole, or anastrozole. All kinds of endocrine therapy options were there with ribociclib. Again, showed a PFS benefit of 23 versus 13 months. So all the approved CDK4/6 inhibitors in first and second line settings have shown a PFS benefit, while the maximum number of trials have shown benefit with ribociclib, Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. Next slide. So do all CDK4/6 inhibitors result in improvement in overall survival? Like we have seen that all the CDK4/6 inhibitors improves progression-free survival. But the better marker in any cancer patient is overall survival. So that is considered as a gold standard in drug approvals. Next slide. So ribociclib is the only CDK4/6 inhibitor to demonstrate significant overall survival in 3 trials. Abemaciclib has also shown significant overall survival benefit in Monarch 2 trial, but that included patients of both first and second line therapy, where abemaciclib was given with fulvestrant. While palbociclib is yet to show any OS benefit, while PFS benefit is there in different Paloma 2 and Paloma 3 trials. Ribociclib in Mona Lisa 2, 3, and 7 in first line and in both first and second line trials has shown significant overall survival benefits with different endocrine therapy partners. Next slide. So Mona Lisa 2 is the largest first-line study in postmenopausal women. It is a phase 3 trial investigating ribociclib plus letrozole in first-line setting in postmenopausal hormone-positive, HER2-negative advanced breast cancer patients. Statistically significant PFS benefit was reported in this trial, 25 versus 16 months. Updated report represents exploratory analysis and showing overall survival benefit also in the final OS analysis. Next slide. So in this trial, Mona Lisa 2, postmenopausal women with hormone positive HER2 negative were taken. No prior therapy for advanced disease was allowed. Prior neoadjuvant endocrine therapy, including tamoxifen, were allowed. Total number of 668 patients were there. They were randomized 1:1 equal arms. In one arm, ribociclib 600 mg per day, 3 week on, 1 week off, with letrozole 2.5 was given, and in the other, letrozole alone with placebo was given. So the primary endpoint was PFS according to CIST 1.1 criteria, and the secondary endpoints were overall survival, ORR, and quality of life. Next slide. So ribociclib achieved longest reported overall survival benefit. It resulted in about 12.5 months. That translates to nearly a year of overall survival benefit. There was 24% relative reduction in the risk of death. So overall survival was 63.9 months versus 51.4 months. Next slide. So it showed consistent overall survival benefit over time. At 4 years, the OS benefit was 5.7%, at 5 years, 8.4%, and at 6 years, 12.2%. Next slide. So in the subgroup analysis, the overall survival benefit was consistent. If we compare with number of metastatic sites, less than 3 metastatic, more than 3, the hazard ratio were 0.77 and 0.70, showing significant benefit in both groups, with liver involvement, without liver involvement, with lung and liver involvement, with and without, with bone lesion only mets, and in de novo patients. So in all the subgroups, the ribociclib plus letrozole combination showed a significant overall survival benefit. Next slide. Ribociclib delayed time to first chemotherapy by almost 1 year. So the median time to chemotherapy in the placebo arm was 38.9 months, about 3 years. In the ribociclib plus letrozole arm, it was 50.6 months, which is more than 4 years. So we can give the patient more than a year of chemotherapy-free lifespan. Another important aspect is that CDK4/6 inhibitors or ribociclib in particular improves PFS and overall survival. But what about if a patient comes with widely metastatic disease where we desire a rapid reduction in tumor size, a rapid reduction in disease volume and load? So how the CDK4/6 inhibitors compare in these kind of patients? So in this Mona Lisa 2 trial, they divided all the patients who responded into 4 groups. Group 1 were the patients who had more than 60% reduction in tumor size at 8 weeks. Group 2 were 35 to 60%. Group 3 were 14 to 35%, and group 4 were patients who had less than 14% reduction in tumor size. So in the ribociclib plus letrozole group, 32% patients achieved more than 60% reduction at 8 weeks compared to 17% patients in the letrozole plus placebo group. So showing that rapidity of response is also there in this group. Next slide. So a large number of patients remained on treatment with ribociclib plus letrozole in the Mona Lisa 2 trial. 30 patients out of 334 are still ongoing as of June 2021 on the treatment arm, while 17 patients are still ongoing on placebo plus letrozole arm. Next slide. So what about the adverse effect profile? Because these agents are little more toxic than the simple aromatase inhibitors, be it anastrozole or letrozole. So we have to carefully manage these patients. The majority of adverse events were, however, predictable, manageable, and reversible. The most common side effect is neutropenia, which is in many patients who have grade 1, grade 2. But in about 52%, in about half the patients, grade 3 neutropenia was also observed. In 10% patients, it was a grade 4 neutropenia. But luckily, febrile neutropenia was observed in less than 1% of patients in this trial. So the other side effects can be abnormal LFT elevation, liver function test can be deranged, but most of these patients had an asymptomatic LFT derangement. Symptomatic disease was not there. Vomiting, nausea, fatigue can be there. Diarrhea can be seen in 38% of patients. Next slide. Next slide. Yeah. So Mona Lisa 2 trial shows us that ribociclib is a well tolerated with highest level of CDK4/6 inhibition. So if we compare CDK4 versus CDK6 inhibition ratio, it is about 8x in ribociclib, 6x in abemaciclib, and equal inhibition with palbociclib. So the major safety concern with ribociclib, the dreaded safety concern I will say is QT prolongation. But if we carefully select the patient, like in this trial, all the patients who had corrected QT interval more than 0.45 seconds were excluded from the study. And then ECG monitoring was done regular to check the QT prolongation. Then we can.
So my apologies. 3 minutes left to conclude your presentation.
Yeah, I'm about to conclude. So we can manage this side effect also. In abemaciclib, we say the major safety concern is diarrhea, which was seen in 86% of the patients. Many patients had mild grade 1, grade 2 diarrhea episode, but yes, some patients do require drug dose interruption and permanent discontinuation due to diarrhea. In palbociclib, there is risk of hematological toxicity like neutropenia. So ribociclib exhibits measurable safety and tolerability profile with more selectivity for CDK4 versus 6 and more drug available to penetrate and act on tumor cells. Next slide. So is ribociclib a rational first-line choice? Combined with endocrine therapy, the only first-line treatment with longer OS benefit, a preferred treatment option for hormone 2 HER2 negative, we can say it can be considered, and has shown consistent OS benefit regardless of endocrine therapy partner, line of therapy, or menopausal status. Next slide. So the only CDK4/6 inhibitor proven to help patients live longer. It results in longest reported median overall survival, longer delay in time to chemotherapy, about 1 year compared to the other arm, improvement and preservation of quality of life because side effect profile is manageable, and established safety profile. Next slide. Thank you.